capacity.
Excellent. Brilliant. Thank you, Narain. And I'll try to be fairly quick. Important to say that I'm presenting on behalf of Mahmoud Labani, who's had to be called away on short notice because of a family bereavement. So this is work that Mahmoud really leads on. So I'm very much sort of presenting on behalf of the whole team. As Narain said at the annual meeting last year, we launched this initiative of a trial for every patient because we think, as Narain said, that we have a unique opportunity in the UK to really make a huge impact, both in terms of our patients nationally, but also to have a big international impact with the research that we can deliver in the UK. And the context is that we have had an excellent track record maybe 15, 20 years ago of being research leaders in our specialty. And over those years, we designed and delivered and published some of the most impactful research in cardiothoracic surgery. But then we kind of had a dip, really, and we sort of stopped doing that for a whole variety of reasons. But we kind of have emerged from that fallow period with an infrastructure that I think for most of us is relatively broken and makes doing trials very, very difficult. So, the things that I hear when I try and talk to people about research is the lack of research support in their units, so the lack of research nurse teams being a really critical example. No time in your job plans to engage with research. Research has sort of fallen down the pecking order of importance for trainees, because there was a time where trainees were expected to do research. That time is now gone. So there might not be the engagement that there used to be from trainees and allied health professionals. And as a result of that, we've sort of lost that national leadership position that I think we held maybe 20 years ago. But I think in the next 4 or 5 years, we have a really fantastic opportunity. And that opportunity really stems from some of the work that Gavin Murphy did in terms of really outlining the research priorities in our specialty with the James Lind aligned exercise. And building on from that, what's really impressive is that we haven't just identified the research questions, but we now have funded research trials that then allow us to deliver the research to answer the questions. And I think for us, it's a real opportunity. It's a real opportunity to build up our research infrastructure. So we now have a host of funded research, which I'm about to talk to you about. And that means that we can now start to kind of employ these research nurses, et cetera, because all these trials come with funding that allows us to build that up. And of course, it allows us to find what the best care is for our patients. That's critical because, of course, almost every therapy that we offer has competing percutaneous options, and it's absolutely imperative that we not only think that we provide better care, but we can demonstrate that in clinical trials, which then influence guidelines, which then influence practice. So I think it's a huge opportunity. The rest of my slides really is to flesh this out. So I'm going to show you a series of trials that are either in progress and requiring people to take part, or about to start and require people to put their hand up to say they will take part, or about to be developed and require input from all of you to try and shape the design of the trial. And as I go through it, I just want you to look at it and think, wherever you are, wherever you work, can we help with this? Is this something we can take part in? And if it is, then please reach out to the investigators and the trial leaders who will get you involved. So really, it's just a sort of slide, a slide of trials, really. And PACES is a really good example of what I'm talking about. So PACES is a trial that's looking at how we manage patients with postoperative AF. This is a very, very common problem. We all have it every day. And the problem is we've never really tested the appropriate treatment for these patients after they go into AF. And PACES is essentially randomizing patients to antiplatelet therapy alone. And as I go around the country, lots of surgeons feel very strongly that patients who go into AF after surgery should not be anticoagulated, or testing, comparing that with anticoagulation. And similarly, there are lots of surgeons who have very strong views about this and think every patient should be anticoagulated after surgery. We genuinely don't know the answer to this question. The trial has never been done. And any evidence we have suggests that the prevailing practice, which is anticoagulating these patients, is probably the worst of the two. So there's lots of data out there that shows that anticoagulating post-operative AF patients only results in lots and lots of bleeding complications and doesn't prevent any stroke or thromboembolic complications at all. But a lot of us do this. So this is a really good example of a trial that every single unit can participate in, because we all do coronary artery surgery, we all have patients who go into AF, and we broadly have quite a lot of variation in the way we manage these patients. So it's up and running. There are 12 centers that are open to pacers in the UK at the moment, and we're looking for at least 20 centers. So if anybody's out there who thinks they can take part in this trial, please do. It's funded by the NIH. And it's there is per patient funding for recruitment, so there's money for you to get research, nurse infrastructure, etc., to help you deliver it. The trial is about halfway through. Internationally, 1,600 patients have been recruited. It's running in the UK, Germany, the USA, and soon to be running in Brazil as well. So really a good example of a very simple trial that will really help all our patients and improve the care that we deliver and the outcomes after our most common surgery, coronary artery bypass grafts. Sorry, just to say that I'm leading PACES, so if anybody's interested, I'm the person to talk to. Faster care is another very good example. So at the moment, most of us operate on patients, and then we see them in clinic at 6 or 8 weeks. And then after we see them in clinic, we give them the thumbs up or the all clear, and then they start cardiac rehab, which then takes 8 weeks. So we've got this very, very long pathway. It takes about 4 months, really, from having an operation to kind of getting over it and returning back to normal. Dombo and Gagi and his group in Hull have done a fantastic feasibility study, which was funded by the NIHR, which demonstrated that we can reduce this pathway significantly by seeing patients at 3 weeks after surgery and starting cardiac rehab at 4 weeks after surgery. And this means that we could potentially reduce the pathway by 6 to 8 weeks, which would be hugely beneficial for our patients. He's then got further funding from HTA and NIHR to run a large multi-center trial across the whole of the UK. He's looking for sites. The trial will open in about 3 months' time. And again, this is a question that we all involves all of us, all the patients we operate on, would like to know whether we can see patients earlier, get them rehabbed earlier, and bring them to the end of their sort of surgical pathway, surgical journey earlier. How fantastic will it be if we can say to patients, actually, the whole pathway only takes 2 months rather than 4 months? But we need this trial to show that it's safe, it's efficacious, and that it's beneficial. And that will then lead to a change in guidelines. So FASTER, I think, is another critical trial. We can all take part. So if you're sitting there thinking, oh, this is a good idea, then Dombo and Gagi, his email is there. He's looking for sites, so please engage with him, because this is a trial that will have an impact on all our patients. Another trial, Type K, again, a lot of you will know about Type K. Type K is actually finishing recruitment, or supposed to finish recruitment in December, although I suspect it will recruit for a little bit longer. Again, looking at the issue of postoperative AF that I've already discussed, a very common problem, and comparing a tightly controlled AF arm with a relaxed, potassium management arm with a relaxed arm, with a view of preventing postoperative AF. This is again a very simple trial. At the moment, there are 20 sites open in the UK. Over 1,000 patients have already been recruited. The sample size is for 1,600. It will definitively answer this question. And so again, if you feel able to, and finally, it is also funded by the BHF, so there's plenty of money for the patients you recruit. So if you feel able to, another very important, very broad trial that we can all take part in. The next one, slightly different, but equally as important, is CO2. This is again funded by NIHR. It's run through Bristol. Ben Gibbison is the chief investigator, and again answers a question that we all ask ourselves in our daily practice. I work in a unit where half of us use CO2. We think it's the most important thing on the planet. We always use it, and we have kittens if we can't use it. And my colleagues on the other side of the corridor don't use it at all. And the question is there any benefit for CO2? So this is a really critical question. The primary outcome is using diffusion-weighted MRI to look for new cerebral infarcts. If CO2 is a good thing, we should all use it because all our patients will benefit. And if it's not a good thing, we should all stop using it because it's absolutely pointless. And this trial, which is looking to recruit nearly 1,000 patients, will answer that question. CO2 has struggled to recruit. I think there are about 300 patients recruited already, and it's under some scrutiny from the NIHR, but it shouldn't be. I mean, we all do open heart cases. Every isolated AVR, every mitral valve surgery should be recruited, and we do thousands of these a year. We only need to recruit 800 patients, and we're basically testing CO2 versus a placebo infusion, which is air. So if you are able to, please contact Ben. This is a trial that really needs to get over the line, that should get over the line because it's really simple, and will again answer a very important question. Right, so the trials keep on coming. This one is slightly different, and I guess this is a trial that I feel particularly passionate about because I feel that in the TAVI versus surgery conversations, we kind of missed out on this because we didn't have surgically led trials. The trials were all led and designed by cardiologists. And after they reported, we all complained about how biased they were, etc. But actually, we have to remember that we didn't organize or run any trials. So primary is an excellent opportunity to get into this space. Primary is a surgical trial. It's designed by CTSN, who we're all familiar with. They've published some of the most impactful trials in the mitral and tricuspid space over the last decade or so. Joe Chickaway and Mark Gillinoff are the leads for the trial, and it's funded by the NIH in the US. But we have the opportunity to take part in this trial in the UK. And primary is comparing surgery with TEER for all comers, all patients over the age of 65, irrespective of risk, and looking at the long-term outcomes of the two therapies. All patients will be followed up for a minimum of 5 years after surgery, and the primary outcome is and importantly is a superiority trial, so not a non-inferiority trial. It's designed to answer the question: is surgery better than TEER? We all think surgery is better, but we have to show it in a randomized controlled trial, because if we do, it then goes into the guidelines and really affects clinical practice and stops the penetration of TEER. So we're just starting primary in the UK. We've got some funding from the British Heart Foundation to do an MRI sub-study as well. So we'll be using MRI to quantify residual regurgitant volumes after surgery to really show the benefit, I hope, of surgery. So if you work in a center where you can offer both TEER and excellent mitral valve repair surgery, then you should be taking part in primary. So please let me know if you're interested. I think this is a critical trial that will guide practice going forward over the next 5 to 10 years or so. The next couple of trials I think the three of them are all from the sort of Gavin Murphy, University of Leicester stable. Again, these are all funded trials, and these are all open to recruitment. The first is TRIX4, which is comparing a liberal versus a restrictive transfusion threshold. Most of us remember the TITRE trial, which was about 10 years old now. TRIX is a much more sort of restrictive threshold for transfusion. It's an international trial, but the NIHR has funded the UK to recruit 320 patients. So TRIX is just about to start. Gavin is running that. So if you're interested in this area, then please let him know. Again, it's a very broad-based trial that should be able to recruit very easily in the UK. Most of you would know that the Roma trial has completed recruitment, and we're waiting for the outcomes of the main trial. But the NIH also decided to fund the Roma women's trial. So this will include women who took part in the overall trial, but now recruitment is going out to only women, 2,000 of them, and to look at the impact of arterial grafting. Again, there's funding from the NIH to recruit 216 patients in the UK. A lot of centers who took part in the main Roma trial are also taking part in Roma women. But I think Gavin is looking for more people to sign up to Roma women. So if you're a coronary artery surgeon who does arterial revascularization and are interested, then again, please contact Gavin to take part in the Roma women trial. This trial has just been funded about 2 or 3 months ago by the NIHR and is to look at revascularization in patients with impaired LV function, comparing PCI and surgery. It's part of a large international trial looking to recruit 2,800 patients. The funding is for the UK to recruit 630 patients. The decision did arrive in May and was positive. So BSIS-4 will be recruiting from early next year. Again, it's a trial about coronary artery surgery with impaired LV. A lot of us have these patients in our practice and so can contribute to this trial. So again, if you're interested, please contact Gavin. And then finally, in terms of the funded trial, there's Prophecy. Prophecy is an excellent trial because, again, it just answers a question for something where there's so much variation in practice. We all are plagued by the problem of bleeding after we do our surgery. I frequently find myself calling for the FFP. The concern is that FFP is a lot of volume, there's a lot of complications, and should we be using Beriplex or prothrombin complex concentrate instead? And if we do a survey across the UK, units use different things, and within units, surgeons use different things. So the NIHR has again funded the study because we made the case that it was important, and it's basically comparing using FFPs or platelet concentrates for patients who bleed after cardiac surgery, with the outcome really being complications from these transfusions after surgery. Again, this should be a really easy trial to do. It's only looking for 500 patients in the UK. And so we should be able to deliver this with some ease. And if you're interested, it's been led by Laura Green from Bart's Hospital. So please get in contact with her or with me, and I will put you in contact with her. So I hope what I've showed you is that this idea that we have a trial for every patient. It's not just a trial for every patient, but it's a funded trial for every patient. So all these trials are funded. And if you are recruiting patients into these trials, it does allow us to start to rebuild that infrastructure that we have lost in terms of trial delivery and really start to sort of challenge our cardiology colleagues in terms of providing evidence for the treatment that we offer. So whatever your interest is, whether it's elective coronaries or urgent coronaries or mitral valve surgery or aortic valve surgery or more complex aortic surgery, there is a trial for every patient you operate on. So really, really critical that we engage in this and are involved. I just want to end really by just talking about 2 trials that are coming along the line, which are not funded, but I think will have significant impact in practice. And I want to raise this because I think we'll all have kind of quite strong views about it. And this is a start of a conversation around it. In some ways, a lot of the trials I've described are the low-hanging fruit. I mean, AF, we just need to sort that. It's lots of patients, you know, it's a no-brainer, CO2, etc. But there's some really important trials that are much more challenging to do, which need to be addressed. And the first is what we do about patients with bicuspid aortic valve stenosis. At the moment, all the trials which guide TAVI practice and which influence the guidelines with which we select patients for surgery or TAVI exclude patients with bicuspid aortic valves. So there's never been a trial that looks at whether patients with BAV should have surgery or TAVI. And so the Navigate bicuspid trial has been an important trial that's been designed to try and answer this question. And the funding application for this trial went in yesterday to the British Heart Foundation, but simultaneously to heart foundations across a number of countries in Europe through a process known as the GCRFF process. So the plan for Navigate is to look at patients with bicuspid aortic valve disease who will then be presented at an MDT and be randomized, if suitable, to a TF arm or to a SAVR arm. Patients who can't be randomized will be entered into a registry. And the plan is that these patients will be then followed up for at least 5 years, and the primary outcome will be the difference between the 2 groups at 5 years. Now, this trial will have a significant impact for surgery because as TAVI penetration has increased, a lot of the patients who have surgery have bicuspid aortic valves. It is an important question. We can't duck it. We can't shy away from it. We need to find out whether, you know, TAVI, whether surgery is still the best option for these patients. And the best way to do that is to do a trial that we're all involved in and all help to design. So I think just watch out for Navigate Bicuspid, because I think it will have a big impact on our practice. The other trial that needs to be done, and that is being planned, is what to do with patients in this age group between 50 and 70. Because increasingly we're seeing that these patients are having tissue valves. There's a huge drive for tissue valves in this age group. And that's driven by the fact that we're seeing more TAVI. We're a bit more confident about how we treat the failing bioprosthesis with percutaneous techniques. We're all using more sutureless valves in our practice. They're tissue valves. And so when you look at the NACSA registry, you see this huge variation. If you live in Hull or the Northern General or Stoke, and you're in this age group, broadly you're having a mechanical valve and you're sticking to what I would regard as conventional practice. But if you're in Manchester or Nottingham or Harefield or Kings, over 70% of patients in this age group are having a tissue valve, and you've got this spectrum of variants across the country. Now, this is in the context of evidence that shows that in this age group, having a bioprosthetic valve is bad for you. And there's lots of papers out there that show that there's a survival hazard to having a bioprosthesis in this age group. And that's been shown in this paper from the Sweetheart Registry and this recent paper, which shows that at 10 years, there's about a 5% difference in mortality between these two groups. So I think this is a really important trial. If we can show that mechanical valves are better in this age group, it will stop the TAVI juggernaut in this age group. And I think this is a trial that we need to think about as a community and deliver. It should be very easy to deliver. There's some issues around sort of design and how we follow patients up for a long time. But I hope that these two trials that I've talked about kind of show the way we're thinking as a research community in cardiac surgery, thinking about how we kind of future-proof our practice and our specialty by providing evidence which supports the excellent work that we do. This is my final slide just to advertise this job. What I've shown you is a really ambitious program of delivering clinical trials. The key thing is that for the first time, the funding bodies have put their faith in us and have given us the money to do this. What we can't do is fail and not deliver these trials and have the funding pulled, because that will really ruin our reputation with the funding bodies for being able to deliver this. So we've put together what we call the National Cardiac Surgery Trials Program Steering Committee, and we want input from all of you to help us make this massive program a success. We're looking for a representative of SCTS on that committee to just try and get through the practical communication issues, jostling units, getting people involved, working through local problems, etc. So I hope that people see this as an opportunity to get involved. So the advert is out. Please have a look at it. If you're interested, get in touch with Mahmood, myself, Gavin, or anyone else on the research committee, and we can talk to you about it. Yeah, looking forward to getting some enthusiastic colleagues to join the team. That's my last slide. Thank you very much for taking the time to listen to me. Thank you.
Thank you, Enoch. Fantastic presentation. And just as Enoch said, there is almost certainly a trial out there with your specific interests and the patients that you operate on, and it would be great to get all of your units involved. We will put the slides up on the SCTS website in a few days, and with Enoch and Mahmood and Babu and Nigel's blessings, we'll get some of these details of these trials out to you by email so that you can disseminate it amongst your colleagues and get people involved. So that'd be fantastic. Next part of our research sort of portfolio is for thoracic surgery, and welcome Babu Naidu from Queen Elizabeth Hospital in Birmingham to take us through that journey.
Thanks. I'm actually presenting on behalf of Eric. For me, it's actually a great pleasure to serve on the Society of Cardiothoracic Research meeting group, because not only does it bring together adult cardiac, thoracic, and congenital team members, but actually it's very much a multidisciplinary meeting with lots of input from the trainees and the HPs. So I really recommend that. It's a very vibrant and sort of active meeting. So please do get involved. I'm not going to present, I haven't got any slides, okay? I'm not going to present a whole barrage of trials that are ongoing, but what I'm going to do is just give you the highs and lows of some of the trials that have finished recruiting and some that are just in the process. So I suppose one of the most important trials that's just finished, and Eric presented at World Lung at the presidential plenary session, was MARS-2. And this was a study comparing thoracotomy decortication in combination with chemotherapy versus systemic therapy alone. And it's a real potential game changer for thoracic surgery in terms of mesothelioma. There was no difference in survival between the two groups. In actual fact, patients who had surgery did far worse. So that's an important study that's just been sort of announced. Another trial that's just completed recruiting is Topic 2, which is a study that we've done in conjunction with our anaesthetists, looking at chronic pain in patients who are undergoing thoracotomy, either with epidural or paravertebral. And Leicester, one of the sites, have just recruited their last patient today. So thanks to all those team members, to all those sites who took part in that study. And we hope to report on that in about 6 to 12 months' time, once the primary outcome is reported. There are two trials which are underway at the moment, which I would like to mention. One is Ramon, and this is led by Eric, and it's the first sort of foray of surgeons into the advanced lung cancer setting. So this is where patients with advanced lung cancer receive systemic treatment, and then, if suitable, go on to have local consolidated therapy, whether that be surgery, SABR, or ablation, versus the standard of symptom control. The study was funded by NIHR, and it's been a real struggle for Eric to actually get that study going, even though there's been quite a lot of support from the surgeons. There have been a lot of logistic reasons. So I think Eric is meeting up with NIHR in the next month or so to decide what the fate of that study will be. And we might need to consider how we can support that further. Another trial, one which I'm leading, funded by NIHR, is Fit for Surgery. This is digital prehabilitation for lung cancer surgery patients. There are 20 centres across the UK involved in this. And thank you very much for all of you engaging in this. We've already had preliminary meetings with sites, and SIVs have happened for a few centres as local approvals come into place. And this is going to be looking at how well digital prehabilitation can help with reducing complications and improving physical recovery after lung cancer surgery. So those are the trials that are in the pipeline. One which Enoch and Nigel are leading is Restore. This is a study which is looking at pectus patients with symptoms and CPET abnormalities. And it was a commission call by the NIHR in response to the change in commissioning. And we have got through to stage 2 of that and answered their comments. And we're hoping that that will be funded, and in which case we'll be looking for around a dozen centres to help with that study to recruit 200 patients into it. So that's something that's in the pipeline. So that's really a summary of the sort of highs and lows of thoracic surgery trials at the moment. The next group I'd just like to very, very briefly mention are the SSLs, Associate SSLs, the surgical specialty leads. And they're both there for cardiac as well as thoracic. They're trainees who actually are there trying to promote and push the research agenda, and they do a number of valuable activities. Just to mention a couple, in thoracic surgery, for example, they have been drawing up the ground glass GGO guidelines for EACS, which will soon be published. They're producing a meta-analysis in neoadjuvant treatment for lung cancer, which is an ever-growing area of practice for us. And they also organize the National Thoracic Research Day, which is in November. I'm sure you've all had the invite to that. It's an online meeting, and I really recommend that you attend it. Really, it's really good value. You can really get a feel for what's going on in the country. So that's the SSLs. And finally, just a quick plug for the National Thoracic Surgery PPI group, Resolve. This was formed in 2016, and as you probably appreciate, in this current era, we can't undertake research without patients being involved in the planning, design, and reporting of studies. And so we have this national group that meets twice a year, once at SCTS and once in November, where researchers can come and present their ideas. So really, it's a request from all of you here to try and identify patients who you feel might be able to contribute this and are willing to contribute to this process, and we'll help train them up. But also, if you have any ideas, you're more than welcome to present at the meeting in late November. So that's a summary of thoracic surgery. Thank you.
Thank you, Babu, to all the work that you and Eric and the team are doing. Similarly, just for thoracic surgeons, please get involved in those trials and come to the team with other ideas of what you want to take forward, because as we said, this is a unique opportunity for us to drive changes in the care of patients that we look after. As the third part of our specialty, Nigel will come and talk about some congenital cardiac surgical research initiatives. Nigel.
Hi, thank you, Narain. Oh, thank you. And just similar to the other speakers, thank you for giving research a platform. I have got slides, but I've got a lot fewer than Enoch did, and that's mainly because we are several years behind our adult cardiac surgery colleagues. So what I wanted to talk about today was just four main things. First of all, an update on the James Jones Alliance priority setting partnership that we've been doing in congenital heart disease. Then what we're doing with that through the Congenital Heart Research Network, and then a brief update on what the ongoing Destiny trial, which is multi-center, and then a brief plug really for a new trial idea that we're looking at. So our priority setting partnership was not just on congenital surgery, it was across all of congenital heart disease. And that was published in December last year. And it's got good traction, and the article's been accessed 2,500 times and PDF downloaded 500 times. So people have noticed it. We had two top 10 lists rather than one child and antenatal and one on adult congenital heart disease. And for this meeting, there were a number of priorities that were related to surgery. These included damage to organs and organ protection following surgery, reducing the frequency or need for reoperations, using technology to personalize care, and outcomes from transplantation and long-term mechanical support. And we felt from the outset of this process that it was important that we didn't just park it there, and that we use this as a catalyst to drive forward congenital research. Historically, the UK, like really the rest of the world, has been pretty sparse on trials, and up until 5 years ago there hadn't been a finished multi-center trial. So therefore we published this document in July, which is Transforming Collaborative Research, and it's a national strategy approved by SCTS, BCCA and others to address the priorities that we've identified in both children and adults. And the core aspect of that is the Congenital Heart Research Network. Historically, there's been a lot of introversion and not participating in other people's studies. And what we want to do is to open that up, to have a collaboration across all centres in the UK and Ireland. Mainly for doing clinical trials, but also other studies if they can demonstrate how they're going to change practice and improve outcomes. And primarily it'll be focused on addressing the priorities, but there's also scope for answering other questions within that. The network plans to provide a framework for investigators to develop and lead studies, and we're currently in the process of setting it up. setting up structures, developing a manual of operations, and our plan are to have biannual meetings. The November one linked to the BCCA. But given the lack of these kind of studies in congenital, there's a lack of experience with it. So we also want to use this as an opportunity to drive training in research skills across the consultant body, the trainees, and the nursing and allied healthcare professionals. Our proposal is endorsed by the BCCA, SCTS, and national charities, and importantly, it's also very supported by NHS Specialised Commissioning in Congenital Heart Disease, and we're planning to launch early next year. So I'll just touch briefly on some of the structures that we're putting in place. BCCA works a bit slower, I think it's fair to say, than the SCTS, so it's taken a little bit longer to get to this point. But it'll have an executive committee which will essentially run the show or oversee things, a scientific committee. Like Babu mentioned, for thoracic surgery, we're setting up a national PPI group in congenital heart disease, and those provide a framework for those individual investigators to come forward and run trials. And I just want to pick up on one aspect of that, which is the executive committee, and I'll explain why. So the executive committee will lead the network and set its direction and strategy, and have responsibility for how it runs, monitor against objectives, including the training aspect, and really set up and run the process. The members of it will include a network chair, which will be elected, a director, which will be appointed on a 5-year term, and initially will be myself. And then it will link with other organisations, so the BCCA president, BCCA scientific secretary, and the SCTS congenital lead. And I mention this because that's currently the post that I fill, but will be vacating in November. So if there's someone who would like to get involved and become the SCTS congenital research lead, please speak up. It'll also link with NICOR and with the national PPI group. And just to show up that at the outset, at least, there'll be a good surgical representation on this. So both myself as the director, the BCCA president incoming in November is Andreas Sazitsky from the Brompton, and also the SCTS congenital lead. So from the outset, whilst it's all of congenital heart disease, there'll be a strong surgical input to driving this forward. I've only got one slide about an active trial, and active comes in brackets, and this is about the Destiny trial. So it's a multi-center trial comparing Del Nido versus St. Thomas's cardioplegia. One of the problems with Del Nido has been that it's the way that it's produced, particularly in the US, is that it's a compounded solution with a very short shelf life. We've developed it as a terminally sterilized product and got MHRA approval for 12 months. And I'll come back to why that might be of wider interest later. It's the first large-scale multi-center trial in the UK in pediatric cardiac surgery. It's opened already at 4 sites, with another 3 joining early next year. But we were partway through recruitment when we had to pause. Completely out of left field, the NHS manufacturing pharmacy that was providing both of the solutions had a major problem with their manufacturing facility and had to close. We looked at all different options, but essentially that's now resolved, and we're planning to restart the trial in the coming weeks. We'll therefore need to extend our recruitment through to the end of December next year. And I mentioned about the Del Nido because in discussions with BISMIX, I did a presentation at the national meeting last year, and there was a lot of interest in Del Nido cardioplegia. It's usually given as a single dose, which has got advantages outside of congenital surgery. And so we're looking to develop a trial focusing on patients undergoing mini-mitral, and there's currently a survey that's open. So if you have received the link and you haven't filled it in, please do. And then finally, a plug for projects that we're working up at the moment. So this is a study on pulmonary valve replacement in adult congenital. And we're looking to develop a multi-center trial to compare 2 types of bronchoprosthesis. That'll likely be a bovine pericardial versus a porcine xenograft. Because there's limited data available, what is out there suggests that there may be a difference in structural valve deterioration between the 2, and therefore an increase in the need for reintervention. And if we can identify one prosthesis better than another, then we can reduce the rate of reinterventions. And this fits in nicely with one of the JLA priorities for reducing the frequency or need for reoperation. So hopefully all the congenital surgeons in the room and listening have received a link for that last week. We'd be grateful if you could fill it in if you haven't already. And I can see some people who already have done, so thank you for that. And we'll aim to present the results at the SCTS annual meeting next year. We've also recently secured funding from the BHF Clinical Research Collaborative to do a systematic review to better understand the endpoints that we can use in the trial, and watch this space. And then just for my last slide, just to mention Michael Kumper, who was a member of our steering committee for the PSP, who was a patient with adult congenital heart disease. And it's really just a reminder that whilst we can anatomically fix the vast majority of lesions, that there's ongoing consequences. So the patients growing up with adult congenital heart disease have a reduced life expectancy, even for the simplest lesions. And sadly, he died just a few weeks after we completed the process. Thank you.
Nigel, thank you, and thanks for the phenomenal amount of work you've been doing on behalf of the congenital community in terms of research. The PSP priority setting partnership with the James and Alliance is a phenomenal piece of work, and I think, as you've outlined, will set strategy moving forward for the next 10 years. So thank you for that. I'd probably welcome Babu and Nigel to just stay up before you try and escape. And also, if we can get Enoch back, at least to see his face. And just to ask questions then from those of you online as well as in the room about to our research leads about the different trials, how you think you can get involved in the different initiatives they're putting forward, and also some of the challenges that you face at a local level. I think one of the points I think Enoch alluded to, because we have similar challenges in our own unit, is about using the research infrastructure and then what funding comes with it. And a lot of the trials that the team have talked about are all funded trials. And I think that is something really important to take back to your units, to say, actually, it will come with money that will allow the research infrastructure in your own units to work. So I would encourage you all just to ask questions to the three of them, and please how you can get involved, but also they may be able to answer some of the challenges that you're having locally. So any questions?
Lorraine, I think it's actually a bit more complicated than just the money, unfortunately. I mean, following COVID, research departments are very, very selective about which studies they will actually drive forward. It's all about capacity. And in this day and age, you can't do the research study without a research nurse. So, and these research nurses are generic usually in most units, only a few have their own. So I think that is a huge challenge. And, you know, I think it's difficult to actually overcome. But I think if the SCTS could support in that, that would be a valuable thing if sites are having a struggle to actually, you know, start the study.
I just want to thank you for your presentation, and I want to echo.
Just introduce yourself.
Oh, sorry. My name is Hatem Nas. I'm the lead thoracic surgeon in Basel Hospital. I just want to echo Babu about what he said, because we had a meeting before with the Fit for Surgery, and I failed to participate because of the lack of the, as you mentioned, research nurse. So what we have planned to do is we're going to recruit more CNSs that want to be involved in the research. So we managed to recruited 3 extra. It is very important and vital structure, because even there's the urge for research, but if you don't have the manpower, people to do research, it's not just about the funding, it's about people who run it. So I'm just going to echo that. We appreciate the support from the SCTS for that as well.
Yeah, I think that's a good model to follow, that if you have people in your departments that are keen to undertake research, and it's in their job plan, it's a part of their job, and there's time for it, then we can provide support either locally or nationally to help them actually come up to speed.
I mean, I echo some of your comments. What we found locally is trying to then use the funding to create the more posts, because without that, we've had some studies that have just been stopped if they don't come with funding. So it is about using that to try and increase the workforce infrastructure. But I share some of your concerns. Any other questions for our research team?
Charaj Akowuah from Bristol. So I've just been wondering whether to bring this up or not as you present initiatives to do more operations in different sectors. One of the things that may be happening around the country is that patients moving from NHS hospitals to the independent sector or other hospitals that don't have the research portfolios that some do, which invariably are sort of the low-risk candidates who are probably more easily eligible to a lot of these trials. So as we initiate these processes, I think to keep in mind the importance of trial recruitment and how, for example, at Aspire or a Cleveland Clinic or wherever they're going to go, how do we maintain this research? Because in one way, you get an email from a research nurse saying that we've got them recruited in a trial. But on the other side, you just want to get the operation done. And it's a conflict. And I find this quite difficult in Bristol, where we recruit a lot of patients and have a reputation to do so and interested to increase. So just wanted to bring that in. I'm not sure it's a big problem just yet, but it may well become as the society and the wider community get into resolving the elective pressures. Thank you.
Can I maybe comment on that? Because that's definitely a problem, Char. And you're right, it's unit specific, but where there are units, sorry, can you hear me?
Yes.
Yeah, you can hear me okay. Where they have a lot of practice going through the independent sector, it's definitely an issue. So, and actually, I haven't found a way of cracking it yet, actually, because there are two things. One is the trials are all insured, obviously, and there's the issues with insurance in the private sector, and the second is the obvious one, which is having research nurse capacity in the private sector. In some places where they're geographically very linked, it's been easy-ish to get research nurses to work across sites, and particularly depending on what they need to collect. So where, for example, a lot of the data collection happens after surgery, then it's easier. You just have the operation, or the follow-up is at home or in a clinic. That's easier. But at trials like, for example, CO2 is a good example where the intervention happens in the operating theatre and you need the randomization to occur in the operating theatre. That can be quite a challenge. But I agree. I mean, I still do think that it's not a huge problem for most of the trials that I've outlined, but it's a situation I've come across, and I can see why it's an issue in Bristol and a number of other centres. But certainly something to keep an eye on going forward. I agree.
Drury?
Thank you all. It's a phenomenal amount of work which all of you have done. And I remember with Babu and Eric going to a thoracic forum saying, how can we work collaboratively to do trials as a registrar? And we have delivered with Topic, Violet, and so on and so forth. But one of the things which I find as a non-academic jobbing thoracic surgeon is if you introduce a trial to the patient, when you consent them and counsel them, then it makes the life of the research nurse much easier to follow on. So that's something which you may want to see, and that's how we ended up being the top recruiter for Topic. But more importantly, a plea to the three of you. One of the things which we are focusing going forwards, wearing my hat as the communication secretary, is to have patient information leaflets for the various surgical procedures and the like, and revamp what is available on the website. So if, as a group, you give us the flyers and the like, we could park them in the patient section in the society website, because more and more patients are coming, having researched about their surgeon, having researched about the unit. So if there is a clinical trial, that's probably a good way to introduce that, and we are quite happy to help you with that. Thank you.
Maybe, Patrice, can I make a point about that? And I think you're absolutely right. Getting to the patients before will be brilliant. Actually, I'm not sure the PISs are the best thing, because actually increasingly PISs are just, in my view, they're quite complex. They're very, very long. They got tons of information. But most of us who do these trials have got kind of shortened things that we can send you. Sometimes they're videos, just 30 seconds telling the patient about the trial opportunity. And I think that might be a better resource than the PISs, because the PISs are quite heavy documents that don't really lend themselves to reading online, I suspect, without someone's talking you through them. But I think that's a really good point.
There's no further questions in the interest of time. Thank you, Enoch, Babu, and Nigel, for all the fantastic work you're doing on behalf of the SCTS and the community for research. So thank you.